Welcome to this next section, Group Medical Expense Insurance. Let's talk about characteristics of group insurance. There are common characteristics between group life, group health, and group disability income and other group policies. Group insurance requires that the group be a natural group. This means the group must be formed for reasons other than to obtain insurance. The most common form of group is employer-employee groups. This means all employees work for a common employer. However, in other groups, the plan sponsor provides benefits for their members. Eligibility requires the plan to not discriminate in favor of individuals in any manner that increases the opportunity for adverse selection against the insurance company. All employees in an employer-employee group of the same class have the same coverage. Eligibility requirements are usually full-time employees, which means 30 hours a week. Unless the employee can prove prior coverage, there can be a waiting period known as a probationary period before the employee is eligible to enroll for coverage. Should an employee not enroll during their eligibility period, they have to wait until open enrollment to apply, which usually is in November of the coming year. Whether it is a group life, group health, or group disability income, insurance, the contract for coverage is between the employer and the insurer, or the plan sponsor and the insurer. The master policy is issued to the employer or plan sponsor, and the employees or plan members receive a certificate of insurance and an outline or booklet describing their benefits. The employee members do not get individual policies. These different types of group insurance coverages have characteristics that are common. The insurance has to be written for the benefit of the employee members. There must be eligibility standards for groups and eligibility for the individual within the group, meaning a full-time employee. Payment can be contributory or non-contributory, and predetermined benefits. All employee members within the same class have the same benefits, and underwriting practices are similar. Group insurance coverage usually costs less and provides broader benefits at a lower cost than individual policies. All group insurance contracts must guarantee renewable. In other words, unless there's non-payment of premium. So all group policies are guaranteed renewable unless there's non-payment of premium, or the employer has committed fraud or intentional misrepresentation, or the employer has not complied with the terms of the health insurance contract. Let's now talk about eligible groups. An employer may be a sole proprietorship, a partnership, or a corporation. That's a single individual. Labor unions, coverage may be direct with the union or union negotiated with multiple employers who build costs into the payment agreement. Eligible group can be a trade association. These plans may be similar to franchise plans and may require evidence of insurability. Individual policies might be issued in this type of plan. Credit or debitor. A credit union may provide coverage as part of membership. A bank may cover loans on a voluntary basis, with borrowers paying the premium and assigning the proceeds to cover a loan. The group must not be less than 10 new members annually, and the premium may be paid by the creditor or through the creditor. Fraternal organizations. Insurance products offered by fraternals to provide access to lower cost for their members. And then franchise or wholesale plans are issued individual policies instead of a master policy, and they may require evidence of insurability, and policies are issued based on the individual's age. The grace period is a minimum of 30 days, and there's no conversion provision because the employees already have an individual policy. And then there's multiple employer trusts, which are established so that small employers of the same industry can band together to purchase as a large group. This lowers the cost and provides greater selection of benefits. Then there's multiple employer welfare arrangements, MEWA, which is similar to a MET, multiple employer trust, except that in EMEWA, a number of employers pool their risks and self-insure rather than purchasing insurance from an insurance company. California law also regulates the types of groups that are eligible to obtain group coverage. Eligible group sponsors include the following: employees and labor unions, or a trust or trustees of a fund established by one or more employers or labor union, professional, trade, or occupational associations, other associations with at least 100 members that were formed for the benefit of the members, and life care contract providers that have received a certificate of authority in accordance with the code. Other types of group plans are co-ops, National Guard, private employee association groups, and state university employee groups, to name a few. These types of groups have higher minimum enrollment, such as at least 25 members that must be enrolled, and that the number enrolled is at least 75% of those eligible to be enrolled. Large association groups still require a minimum of 100 participants. The purpose of these requirements is to ensure that a group has been organized as a legitimate group that will provide services and benefits to members rather than formed primarily for the purchase of obtaining or selling group insurance. Before selling a group, the agent should therefore verify that the applicant is indeed a legitimate group. Let's now talk about small versus large groups. With the passage of the Affordable Care Act, small employer means an employer who employs an average of at least one, but not more than 100 employees on business during the preceding calendar year, and employs at least one employee on the first day of the plan year. In California, for plan years from 2014 to 2015, small employer meant one who is actively engaged in businesses or services on at least 50% of its working days during the preceding calendar year or quarter, and was not formed primarily for purposes of buying health insurance. They employed at least one, but not more than 50 eligible employees, the majority of whom were employed in this state and for whom a bona fide employer-employee relationship exists, and they offer coverage to all of the employees. Prior to the ACA, California groups required a minimum of 2 employees to qualify as a group. California also requires that majority of employees in the group reside in California and that coverage be guaranteed issued. Note, however, since 2016, when California's small group insurance market expanded to include employers of up to 100 employees, employees in the state will use the same method of counting full-time and full-time equivalent employees toward that threshold as is required under the ACA's Employer Shared Responsibility rules. In other words, they have rules on how you count employees. 2 part-time employees equal 1 full-time employee equivalent. Let's look at the California requirements for employee eligibility. Group life, health, and disability income plans impose a set of eligibility requirements that must be met before a plan member or employee is eligible to participate in the group plan. Here are the eligibility requirements for employees. It must be full-time, and that's defined as somebody working 30 hours or more per week. Employer has the option to offering coverage to part-time employees, defined as those working 20 to 29 hours per week. If the employer offers coverage to any part-time employee, they must offer to all part-time employees. The following individuals are usually not eligible for small group medical coverage: employees covered under a collective bargaining agreement, employees of unrelated companies or organizations, independent contractors, non-employee directors of the company, retirees, seasonal employees who only work 3 or 4 months in the summertime, and temporary employees. While the Affordable Care Act prohibits group health plans from imposing a waiting period that exceeds 90 days, a California law prohibits waiting periods of more than 60 days. This requirement applies to small and large group plans alike, regardless of the grandfathered status. Plan sponsors should work with the California group policy issuers to ensure compliance for policies beginning on or after January of 2014. This waiting period is sometimes referred to on the test as the probationary period. So this is the time where a new employee has to wait before they can join the group plan. Let's now talk about contributory versus non-contributory plans. In an effort to protect the insurance company against adverse selection, any group plan, whether life, health, or disability income, will be contributory or non-contributory. In a contributory plan, the premium normally is being shared between the employer and the employee. The employee pays part of the cost with a deduction out of his paycheck. If the employee is contributing the entire premium, it is still called a contributory plan. This is a trick question on the test. In a contributory plan, 75% of eligible employees must be enrolled. In a non-contributory plan, the employer pays the entire premium and 100% of eligible employees must be enrolled. The small groups may only require 50% be enrolled. Let's talk about coverage forms. Employers setting up a health plan need consider both the type of health plan to offer and how the health plan will be structured. There are two common ways to structure a group health insurance plan: fully insured and self-insured or self-funded. Let's look at the care plans, HMOs, POS, PPO, and EPO. Managed healthcare has become the key strategy for containing rising healthcare costs. Studies have indicated that managed care costs grow at a much slower pace than traditional indemnity plans. To achieve their objectives, managed care plans selectively contract with healthcare professionals, establish financial incentives for members to use providers and procedures approved by the plan. They control expenses and hospital admissions and the length of stay for the various hospital surgeries, for example. They utilize utilization review management tools that include utilization review, standardized medical practice, guidelines, and case management. And they emphasize disease prevention and health promotion programs. And they have mandatory second opinions required and pre-certification review, and they offer ambulatory surgery, which is where you go into the hospital, have the surgery, and go home the same day. You don't necessarily walk out, you might be in a wheelchair, but they call it ambulatory surgery, in and out in one day. These plans can either be fully funded, which means paid for by the employer, or self-funded. Fully funded means they're buying insurance. They're paying a premium and buying insurance. Self-funded means all the claims are being paid by the employer's own money. Let's have more details about that. Self-funded plans are used primarily as an alternative to purchasing insurance. It allows the plan sponsor or employer to tailor the plan to meet their needs. A self-funded plan can be designed as any of the managed care plans or as an indemnity plan. Instead of paying premiums to an insurance company for benefits that may or may not be used by the plan members, the plan sponsor or employer pays the claims out of operating capital instead of being paid by an insurance company. For a self-funded plan to work, it requires that the risk be known and predictable. For a risk to be successfully self-insured, two important characteristics must be present. It must be a large group, so that the law of large numbers can be used to predict expected losses, and there must be sufficient liquid assets in the company to pay claims and other administrative costs. To protect themselves from catastrophic losses, or even just losses higher than predicted, the plan can be backed up by a stop-loss contract with an insurance company. In other words, once payments in the plan exceed $2 million, then the rest of the claims will be paid by the insurance company. That's called a stop-loss contract. A self-funded plan can be administered by the employer, by an insurance company, under an administrative services only contract, or by a third-party administrator. A fully funded plan is a more traditional way to structure an employer-sponsored health plan. With a fully funded insured health plan, the employer will be in charge of enrollment, premium payments, benefit selection, and any administrative functions not provided by the insurance company. The insurer collects the premium and pays the health care claims based on the coverage benefits outlined in the policy. The covered persons, i.e. employees and dependents, are responsible to pay any deductible amounts, co-pays, or co-insurance payments required for covered services under the policy. Let's now talk about consumer-driven models. A flexible spending arrangement, FSA, is commonly known as a flexible spending account, is one of many tax-advantaged financial accounts that can be set up through a cafeteria plan by an employer. An FSA allows an employee to set aside a portion of his earnings to pay for qualified expenses as established in the cafeteria plan. Most often these expenses are medical expenses. However, they can also use for dependent daycare. You can have money deducted from your paycheck, put in your FSA account, and you can use that to pay your daycare provider. So it saves you paying income tax on the money that you're using to pay for daycare, also money you use to pay for your medical expenses. The annual dollar limit of an employee contribution to the employer-sponsored FSA rises to $2,750 in 2020, up from $2,700 in 2019. Both the employer and the employee may contribute to an employee's health FSA, but contributions from all sources combined must not exceed $2,750 annual limit for 2020. The annual limit for a dependent care FSA or dependent care assistance plan will remain at $5,000 for qualifying individuals and those who are married and file a joint return, and will remain at $2,500 for those who are married and file a separate return. So just remember, to contribute to an FSA that's going to be used for health insurance, the most you can contribute in pre-tax dollars is $2,700. But if you're using your FSA for child care dependent care payments, you can contribute $5,000 into that each year. FSAs are tax-free accounts to pay health care costs. They are not insurance. Flexible spending accounts and HSAs, health savings account, both allow the employee to set aside pre-tax dollars to pay for qualified health care expenses. However, HSAs are different from FSAs in several ways. The money set aside for an FSA must be spent during the same tax year or the employee will lose it. HSA money, however, can stay in the account forever, earning interest until it's needed. The HSA money rolls over from year to year. But your FSA, you got to spend it all this year or you lose it. Qualified expenses are different for a flexible spending account, than they are for a health savings account. For example, money from an FSA can be used to pay for child care as well as health care. Whereas your HSA, the money can only be used for health care. Then there's a third account, the Health Reimbursement Account, or HRA, is an employer-funded program where a health reimbursement account or personal care account is associated with a health care plan. An HRA is a type of employer group health care plan that reimburses employees for qualified medical expenses. HRAs are initiated by the employer and serviced by a third-party administrator or plan provider. The employer may provide in the HRA plan documents that a credit balance in the employee's HRA account can be rolled over from 1 year to the next like a savings account. The employer decides if the funds are rolled and how much rolls over. It can be either a flat amount or a percentage. These are IRS-sanctioned programs that allow an employer to reimburse medical expenses paid by participating employees, thus yielding tax advantages to offset health care costs. According to the IRS, an HRA must be funded solely by the employer, and contributions cannot be paid through a voluntary salary reduction agreement. There is no limit on the employer's contribution, which are excluded from an employee's income. So the employer can set up HRAs, which means they're just going to self-fund the employee's medical expenses. You go to Kaiser, you get a bill, you send it to the employee development or the Employee Benefits Department, and then they reimburse you from the HRA, Health Reimbursement Account. Okay, let's talk about HSA in more detail, Health Savings Account. A type of savings account that lets you set aside money as an employee or as an individual on a pre-tax basis to pay for qualified medical expenses. By using untaxed dollars in a health savings account to pay for deductibles, co-payments, co-insurance, and some other expenses, you may be able to lower your overall health care costs. HSA funds generally may not be used to pay premiums, only expenses. While you can use the funds in an HSA at any time to pay for qualified medical expenses, you may contribute to an HSA only if you have a high deductible health plan, HDHP. Remember, for year 2020, the minimum deductible for an HDHP, high deductible health plan, is $1,400 for an individual and $2,800 for a family. For 2020, if you have an HDHP, you can contribute up to $3,500 for self-only coverage and up to $7,100 for family coverage into your HSA. So your high deductible health plan has to have at least an annual deductible of $1,400, and if it does, you can put $3,500 for yourself into your HSA and up to $7,100 for your family into your HSA. Let's now look at coverage for dependents. Group health insurance may be extended to the insured's employees' dependents, allowing them to elect to cover one or more dependents. If the employee is not covered by the plan, the dependent cannot be enrolled into the plan. Dependents are to receive the same coverage benefits as the insured. A dependent is a son, daughter, stepchildren, adopted children, and eligible foster children. Beginning in 2015, larger employers must offer coverage to employees' dependents, otherwise they are assessed a penalty. So big company group health plans have to offer you medical coverage for employees' dependents. Group health insurance policies and healthcare service plans that provide dependent coverage must comply with California's dependent coverage laws. This does not include specialized healthcare service plans, Medicare supplements, or limited policies. The following lists the length of time that the dependent may be covered under the California law. Children up to age 26, a dependent child does not need to reside in your same household, but if you're providing a majority of their care and claiming them as a dependent on your income tax, you can keep them on your health insurance until age 26. You can keep them beyond age 26 if the child is enrolled as a full-time student at a secondary or post-secondary educational institution. So if your student is working on a master's degree or doctorate degree and they're still full-time, you can keep them on your health plan after age 26. And beyond age 26, if the dependent is mentally or physically handicapped and is incapable of having a job and being self-supportive, you can keep that child on your health plan forever. Let's talk about domestic partnerships. A domestic partnership is established when persons meet the criteria specified by California's Family Code, Section 297. They can either file a declaration of domestic partnership form or a confidential declaration of domestic partnership with the California Secretary of State. In order to qualify for registration, couples must meet these basic elements. The partners have to be unmarried. Both persons are at least 18 years of age. They're not related by blood in any way that would prevent a legal marriage in California. They're capable of consenting to the domestic partnership agreement and are both of the same gender, or one or both of the persons meets the eligibility criteria under Title II of the Social Security Act is defined in Section 402. In other words, they're old enough to take Social Security. Notwithstanding any other provisions of this section, persons of opposite sexes may not constitute a domestic partnership unless one or both are over age 62 years of age. So the domestic partnership law was basically designed to benefit the LGBTQ community and allowing them to declare domestic partnerships before it was legal to be married in the state of California. And you can't be domestic partnership if you're of opposite sexes, unless you're over 62, where one of them could be male and one could be female. Under the California Insurance Equality Act, California insurance providers and HMOs that provide hospital, medical, or surgical expense benefits for employers and their spouses must treat registered domestic partners of covered employees the same as spouses in all aspects of insurance coverage. California was one of the first states to pass that law. Let's now talk about blanket coverage. Blanket accident and health is a group policy that provides coverage to a group of people who are exposed to the same risk, but the individuals within the group are constantly changing, which creates an administrative nightmare if each person had to be added or deleted to the policy. They don't. The coverage is blanket. Those covered by the plan are not identified by name or social security number. The certificate of insurance is not issued. Participants may be covered only for a few hours on some of these policies. Examples are passengers on an airline. You can buy a policy for just your trip, or universities use them to provide health insurance to enrolled students. And there's also plans to insure sports teams or migrant farm workers or religious or civic organizations. These policies must all be filed and approved by the California Insurance Commissioner. Let's look at large group health underwriting. Millions of Americans get their health insurance coverage through large employers. Currently, those with businesses more than 50 employees are considered large employers. The laws about how coverage can be issued to large groups are different than those for small groups, and the way the premium rates are determined is also different. However, unlike the individual and small group market, large employers use experience rating to determine premium, which is the practice of determining premium rate for the large group market based on the claims experience of the employees in that large group. So the individual and small group policies are rated using adjusted community rating for the whole community, like Northern California, but a large group policy at an employer uses its own claims experience from that group to determine the rates going forward. So a lot of people in that group have cancer, a lot of medical costs. That group rate can go up substantially. Whereas small group policies and individuals use the entire rating for the whole general market area, which then tend to be more even and averaged out. Large group insurance carriers cannot decline business if it meets the insurance company's underwriting guidelines, but they can legally offer rates that are so high that it's effectively a declination. Also, a health issuer must offer to a large employer all products that are approved for sale in the large group market. Rates based on employee participation and prior claims experience. Health insurance companies base annual premium changes for large employer groups primarily on the claims experience of the group in its past years, as well as any overall increases in the cost of providing health coverage, meaning their expenses. Let's now talk about small group. There's a table in your text that compares the market and regulatory features affecting California's small group purchasers before and after January 2014, which is when the ACA, Obamacare, was implemented. So you should study that chart in your text. It shows the differences between healthcare pre-Obamacare and the differences post-Obamacare after the law was passed. Guaranteed issue. Federal and state laws require all plans sold to small groups, employers with 2 to 50 employees, to be sold on a guaranteed issue basis. That means small employers cannot be turned down by an insurance company based on the health status of their group. Small employers might be ineligible to buy coverage for other reasons besides health status. For example, insurance companies might have requirements that small employers contribute a minimum percentage of the premium payment on behalf of their employees, or that a minimum percentage of the small firm's employees participate in the health plan. Federal law does not require guaranteed issue for the self-employed, sole proprietors with no employees, However, states can, and in some cases do, apply broader guaranteed issue requirements. California does not issue small group as a group of one policies. Small business healthcare tax credits. We'll be discussing the health insurance exchanges in the next section, which provides qualified health plans to both individuals and group employers. Those individuals that qualify for tax credits or subsidies to pay for their health insurance must purchase their coverage through the exchange, which is known as Covered California for small business. However, insurance may be purchased outside the exchange, and the rules for guaranteed issue and core coverage are the same. Certain small business employers who offer coverage to their employees and who pay a portion of their employees' premiums are eligible for a tax credit. These tax credits have been available since 2010. The exact amount of the employer's tax credit is based on the number of full-time employees and their average wages. The fewer the number of employees and the lower the wages, the greater the tax credit. The credit is available for the employer if he has fewer than 25 full-time equivalent employees and paid average annual wages of less than $54,000 per employee. The limit has been adjusted for inflation each year since 2014, so it goes up a little bit. And you have to cover at least 50% of the cost of single coverage for each employee. For purposes of the tax credit, the business owner and any of the owner's family members who are on the payroll are not considered employees. So from 2010 to 2013, the maximum tax credit amount was 35% of the premiums paid by the eligible small employer and 25% of premiums paid by eligible tax-exempt organizations like a nonprofit. Since 2014, the maximum credit amount has been 50% of premium expenses for for-profit businesses and 35% for tax-exempt businesses or nonprofit businesses. For example, 10 full-time employees was $250,000 total. That would be an average of $25,000 payroll per employee. If the employer contributed or paid to the employee's health insurance was $60,000, the employer could get half of that back as a 50% tax credit. So the tax credit is designed to help motivate small employers to pay for health insurance for their employees because they get a 50% discount. They save half the cost on their taxes. The tax credit is a direct one-for-one offset against the taxes the business pays. If the employer's cost of providing Covered California for small business coverage exceeds the premium credit, the balance of that can still be deducted as a deductible tax expense by the business. Let's now talk about qualified small employer health reimbursement arrangements. It's a weird acronym, QSEHRA. Certain small employers, generally those with less than 50 employees that don't offer a group health plan, can contribute to their employees' health care costs through the Qualified Small Employer Health Reimbursement Arrangement. A QSEHRA allows small employers to provide non-tax reimbursement of certain health care expenses like health insurance premiums and co-insurance payments to employees who maintain minimum essential coverage, such as a plan from the individual marketplace. In many states, QSEHRAs allow small employers to provide their employees additional plan choices without managing group health care coverage. Let's take a look at the impact of legislation on group health insurance. Lots of different laws have been passed that affect group health insurance products and marketplace. Though insurance is primarily regulated on a state basis, the federal government has also exercised its regulatory prerogative by passing laws that protect individuals' and employees' rights concerning insurance, benefits, and rights of privacy. These regulations were also affected by the passage of Affordable Care Act. Here are a few of the federal laws that have impacted group health insurance. The first we're going to talk about is the Employee Retirement Income Security Act of 1974, ERISA. ERISA was enacted to ensure the protection of employee pensions and other benefits promised by an employer. A complex set of rules under the ERISA Act covers pensions, profit sharing, stock bonuses, health and life insurance. ERISA regulations can and will supersede almost any state laws in connection with the protection of benefits for the employee. It's the single most important federal standard for employee benefits. ERISA does not require that an employer provide health insurance to its employees or retirees, but it regulates the operation of health benefit plans if an employer chooses to establish one. All covered employees and beneficiaries of a group plan must be provided with a summary plan description that describes the plan in understandable terms, and they must describe how benefits are paid, when benefits are not paid, and employees' rights and responsibilities. Employees must be provided a notice called a summary of material modifications when a significant change is made to the plan. In general, ERISA does not cover group health plans established or maintained by government entities, churches for their employees, or plans which are maintained solely to comply with applicable workers' compensation, unemployment, or disability plans. It's really only for private plans by private employers. Let's now talk about the next major piece of legislation, the Consolidated Omnibus Budget Reconciliation Act, commonly known as COBRA. A law enacted in 1986 helps workers and their families keep their group health coverage during times of voluntary or involuntary job loss, reduction in hours worked, or transition between jobs, and certain other cases. The law, the Consolidated Omnibus Budget Reconciliation Act, or COBRA, gives workers who lose their health benefits the right to choose to continue group health benefits provided by the plan under certain circumstances. COBRA generally requires that the group health plans sponsored by employers with 20 or more employees in the prior year offer employees and their families the opportunity for a temporary extension of health coverage, called continuation coverage, in certain instances where coverage under the plan would otherwise end. Provisions of COBRA coverage, state and local government plans, are administered by the Department of Health and Human Services. Several events that can cause workers and their family members to lose group health coverage may result in the right to COBRA coverage. These include voluntary or involuntary termination of the covered employee's employment for reasons other than gross misconduct, reduced hours of work for the covered employee becoming entitled to Medicare, divorce or legal separation of a covered employee, death of a covered employee, and loss of status as a dependent child under the plan rules. Under COBRA, the employee or family member may qualify to keep their group health plan benefits for a set period of time, depending on the reason for losing their health coverage. There's a chart in your text that gives an example of the various conditions that can rise to using COBRA. You should study that. Events that terminate COBRA. Once you're on COBRA, you can't keep it forever. COBRA continuous coverage terminates when the qualified beneficiary becomes covered under another group health plan as a result of employment, reemployment, or remarriage, so long as the other plan does not exclude a pre-existing condition of the beneficiary. In 2014, under the Affordable Care Act, pre-existing conditions exclusions will no longer apply. In addition, no continuation coverage need be provided after failure to make timely premium payments under the plan. In other words, if you don't pay your bill, the qualified beneficiary enrolls in Medicare after electing COBRA, or the employer ceases to maintain any group health plans. So you could still lose your coverage if the company plan itself is completely terminated. There's notification requirements under COBRA. An initial notice must be furnished to covered employees and spouses at the time coverage under the plan commences, informing them of their rights under COBRA and describing provisions of the law. COBRA information is also required to be contained in the policy's plan summary documents that you get when you first become an employee. Premium payments. Qualified individuals may be required to pay the entire premium for coverage, which can be up to 102% of the cost of the plan. Premium may be higher for persons exercising the disability provisions of COBRA, and failure to make timely payments may result in the loss of coverage. Let's now talk about COBRA and the covered California exchanges. Consumers are not obligated to participate in COBRA after leaving a job. If a consumer declines the initial offer of COBRA and is therefore newly uninsured, then he or she will be able to qualify for special enrollment in the covered California health insurance plan outside of the annual open enrollment period. To take advantage of the special enrollment opportunity, they must apply for and select a covered California plan no later than 60 days after their employer-sponsored coverage ends. Next major legislation is the Americans with Disability Act, ADA. That's easier to say than some of these other mouthfuls. The ADA Act was passed in 1990, which took effect in July 26, 1992, prohibits private employers with 50 or more employees, state and local governments, employment agencies, and labor unions from discriminating against qualified individuals with disabilities in job application procedures, hiring, firing, advancement, compensation, job training, and other terms, conditions, and privileges of employment. This act prohibits employers from rejecting job applicants with disabilities on the foundation that disabled employees will increase costs of group health care benefits. Employers also cannot reject applicants for employment on the grounds that their spouse or dependents are disabled. Let's now talk about the Family and Medical Leave Act, FMLA. FMLA requires employers of 50 or more employees to provide up to 12 weeks of unpaid job-protected leave to eligible employees. Qualifying events are for incapacity due to pregnancy, prenatal medical care, or childbirth, to care for the employee's child after birth or placement or adoption of a foster care child, to care for the employee's spouse, child, or parent who has serious health conditions, for serious health conditions that make the employee unable to perform the employee's job, and then the military family leave entitlement. Special leave entitlement permits eligible employees to take up to 26 weeks of leave to care for a covered service member during a single 12-month period. Covered service member is a current member of the Armed Forces, National Guard, or Reserves who has a serious injury or illness incurred in the line of duty. During FMLA leave, the employer must maintain the employee's health coverage under any group health plan on the same terms as if the employee had continued to work. Upon return from FMLA leave, most employees must be restored to their original or equivalent positions with equivalent pay, benefits, and other employment terms. Let's talk about eligibility requirements. Employees are eligible if they've worked for a covered employer for at least 1 year for 1,250 hours over the past 12 months, and if at least 50 employees are employed by the employer within 75 miles of your home. The 12 weeks of leave does not need to be used in one block. Leave can be taken intermittently or on a reduced leave schedule when medically necessary. Employees are to provide 30 days advance notice to the employer when the need is foreseeable. Let's now talk about the Pregnancy Discrimination Act. Pregnancy discrimination occurs when an expectant woman is fired, not hired, or otherwise discriminated against due to the pregnancy or intention to become pregnant. Common forms of pregnancy discrimination include not being hired due to visible pregnancy or likelihood of becoming pregnant, being fired after informing an employer of one's pregnancy, being fired after maternity leave, and receiving a pay reduction due to pregnancy. Since 1978, employers are legally bound to provide the same insurance, leave pay, and additional support that would be bestowed upon any employee with medical leave or disability. And this only applies to companies with 15 or more employees. In 2002, California Paid Family Leave Insurance Program was passed, also known as the Family Temporary Disability Insurance Program, and it extended unemployment disability compensation to covered individuals who take time off work to bond with a new minor child. The PFL covers employees who take time off to bond with their own child or the registered domestic partner's child, or a child placed for adoption or foster care with them or with their domestic partner. It enables a woman to take 4 months of pregnancy unpaid leave even if she is a new employee and even if she does not work full-time. Employer-sponsored health insurance must cover expenses for pregnancy-related conditions on the same basis as costs for other medical conditions. Pregnancy-related expenses should be reimbursed exactly as those occurred for other medical conditions, and no additional or larger deductibles can be imposed. Employers must provide the same level of health benefits for spouses of male employees as they do for spouses of female employees, and cannot be limited to married employees only. The health plan does not have to provide coverage for abortion except where the life of the mother is endangered. Let's talk about the next law, the California Family Rights Act, CFRA, can be used to take additional time beyond the pregnancy disability leave. However, just like the Family Leave Act, it only applies to employers with 50 or more employees. If a person can meet the eligibility requirements for CFRA, California Family Rights Act, she can take both this leave and the pregnancy disability leave. This means those who qualify can take the 4 months of pregnancy leave along with up to 12 weeks of CFRA leave for bonding with the baby after birth for a total of 7 months off. This works if you're employed by an employer with 50 or more employees. The next legislation is HIPAA, the Health Insurance Portability and Accountability Act, HIPAA. The HIPAA privacy rule provides federal protection for individually identifiable health information held by covered entities and their business associates, and gives patients an array of rights with respect to that information. At the same time, the privacy rule is balanced so that it permits the disclosure of health information needed for patient care and other important purposes. The HIPAA security rule, which sets national standards for the security of electronic protected health information and confidentiality provisions of the new patient safety rule, which protects identifiable information being used to analyze patient safety events and improve patient safety. Now let's talk about the Affordable Care Act's effects on HIPAA. The Patient Protection and Affordable Care Act requires Health and Human Services, HHS, to issue operating rules for HIPAA's standard transactions to make the information and transmission formats more uniform and reduce the role of plan-specific companion guide. Let's talk about new privacy rules and how they apply to the ACA. In January 2013, the U.S. Health and Human Services Offices for Civil Rights released a long-awaited final regulations expanding privacy rights for patients and others. These new rules trigger major changes in medical record privacy measures required for health providers by 2 federal laws, the Health Insurance Portability and Accountability Act, HIPAA, enacted in '96, and the Health Information Technology for Economic and Clinical Health Act, HITECH, enacted in 2009. The final omnibus rule greatly enhances a patient's privacy protection, provides individuals new rights to the health information, and strengthens the government's ability to enforce the law. The changes in the final rulemaking provide the public with increased protection and control of their personal health information. Individual rights are expanded in important ways. Patients can ask for a copy of their electronic medical record in an electronic format. When individuals pay by cash, they can instruct their provider not to share the information about their treatment with their health plan. The final omnibus rule sets new limits on how information is used and disclosed for marketing and fundraising purposes and prohibits the sale of an individual's health information without their permission. The new rules clarified that genetic information is protected under the HIPAA privacy rule and prohibits most health plans from using or disclosing genetic information for underwriting purposes. The new protections give patients greater access to their own medical records and more control over how their personal information is used by their health plan and healthcare providers. Let's now talk about how HIPAA extends to all married couples. Since the U.S. Supreme Court ruled in June 2013 that the portion of the federal law defining marriage as a legal union between man and woman was unconstitutional, federal agencies have been reviewing their regulations to see which may need to be altered to grant certain rights to married gay couples. In September 2014, the HHS Office for Civil Rights issued guidance clarifying that as a result of the Windsor versus United States Supreme Court decision, the definition of marriage, family, and dependent in the privacy rule was expanded to include same-sex couples who are legally married. Given the ruling on the Defense of Marriage Act, the term now applies to all individuals who are legally married, whether or not they have or live or receive services in a jurisdiction that recognizes their marriage. So if you're in a state that does not recognize gay marriage, the federal law takes precedent. Let's now talk about CalCOBRA. The California Continuation Benefits Replacement Act, CalCOBRA, is a California program that's similar to the federal Consolidated Omnibus Budget Reconciliation Act, or federal COBRA. Both provide certain former employees, retirees, spouses, former spouses, and dependent children the right to temporarily continue of employer-sponsored group health coverage when they would otherwise lose the coverage because of certain qualifying events, such as the loss of a job or a divorce. Qualified individuals may be required to pay the entire premium for coverage up to 110% of the cost of the plan. CalCOBRA applies to employers and group health plans that cover from 2 to 19 employees. Note that CalCOBRA also applies to an employer with more than 20 employees when the employee has exhausted his or her 18 months on the federal COBRA plan. CalCOBRA allows individuals to continue their group health coverage for up to 36 months. For example, individuals covered under federal COBRA and CalCOBRA may also be used to extend health coverage for a combined period of 36 months, 18 months on national COBRA and another 18 months on CalCOBRA. Let's now talk about the Mental Health Parity and Addiction Equity Act, MHP-AEA. This act was enacted to ensure parity or fairness between mental health and/or substance use disorder benefits and medical surgical benefits covered by a health plan. Enacted in 2008, the MHP-AEA does not require a plan to offer mental health or substance abuse benefits, but if the plan does so, it must offer the benefits on a par with the other major surgical benefits it covers. The final rule is effective for plan years beginning after July 1, 2014, and in practice, most plan years begin on January 1, so the effective date of the majority of plans covered by this legislation was January 1, 2015. A simple example of a parity requirement would be the frequency of office visits. Under this plan, an insurance company cannot allow a patient to have an unlimited number of medically necessary appointments with the dermatologist, but limit patients to only 5 appointments with a psychiatrist. Let's look at some of the key definitions here. The MHP-AEA applies to individuals and small groups sold in and outside of the health insurance marketplace as part of the essential health benefits. the 10 essential health benefits. Plans and insurance companies are prohibited from doing these things. They can't impose financial requirements or quantitative treatment limitations on mental health and or substance abuse disorders. They can't have cumulative requirements, deductibles or out-of-pocket maximums, or cumulative quantitative treatment limits, annual or lifetime day or visit limits on mental health or substance abuse coverages that accumulate separately from the medical surgical benefits. And you can't require a patient to go to a mental health, or substance abuse facility in their own state if the plan allows plan members to go out of state for other medical services. And you can't impose these tiered networks more stringently on mental health and substance abuse coverages. And a plan may not apply these tiered prescription drug programs more stringently on mental health and substance abuse prescription drugs. So you basically can't discriminate on your coverage levels for mental health services and substance abuse services. Let's now talk about affordability under the Affordable Care Act. As of January 1, 2015, the employer shared responsibility payment, the employer mandate, applies to some large employers who don't offer insurance that meets certain minimum standards. Employers with 100 or more full-time employees, known as full-time equivalent, FTE, meaning you count your part-time employees' hours, so 2 part-time employees that work 20 hours a week each is really counted as 1 full-time equivalent employee. Employers counting their FTE, full-time equivalent employees, must offer health insurance to their employees and dependents or pay a penalty. So after January 2015, employers with 100 or more full-time employees must offer health insurance or pay a penalty. Companies that employ between 50 and 99 full-time employees did not have to comply with this requirement until 2016. Any business claiming eligibility for the 1-year delay because it had fewer than 100 employees must certify that it did not reduce its workforce merely to qualify for this delay. So now all employers with over 50 employees must offer health care. Companies with 100 or more employees had to offer health insurance to 70% of their full-time employees in 2015 to comply with the revised rules instead of 95% originally proposed in the regulations. 2016 and beyond, the offer must be extended to at least 95% of their full-time employees. Employers with fewer than 50 full-time employees are totally exempt from this mandate. There's a chart in your text that shows employer size and the years in which they must offer these coverages. The penalties and fees if you don't. For employers who don't provide coverage to at least 95% of full-time employees, the penalty fee is $2,570 per full-time employees minus the first 30 full-time employees. For employers who do not provide coverage, who do provide coverage, but do not provide coverage meeting the minimum value and affordability requirements, the fee penalty is lower. It's the lesser of $2,570 per full-time employee minus the first 30 employees, or $3,860 per full-time employee receiving a federal premium subsidy. Coverage offered to employees must be considered affordable, which means the premium for the employee only, not including their dependents, has to be less than 9.78% of the employee's household income. The employer's plan is considered minimum value if the plan pays at least 60% of the average cost of covered benefits. In general, the fee is only triggered if at least one employee shops on the marketplace and is eligible for a federal premium subsidy. So if one of your employees who has your minimum coverage shops on the marketplace and he's eligible for federal premium subsidy, you can get fined. Also, the employer mandate is based on full-time equivalent employees, not just full-time employees. It's adding up all the part-time hours together to count up full-time equivalent. The fee is based on whether you offer affordable health insurance to your employees that provide the minimum value. Employers have to offer coverage to substantially all 95% of their full-time employees. Coverage must be offered to dependents up to age 26. Once a dependent turns 26, coverage no longer needs to be offered. Spouses do not count as dependents, and coverage does not have to be offered to spouses. Employers must offer coverage, but employees don't have to take it. That being said, they can't get marketplace subsidies if coverage meets affordability and minimum value guidelines. Since the employee was offered qualifying coverage, the employer doesn't owe the fee. In other words, if your employee turns down health insurance and your health insurance meets the minimum guidelines, that employee cannot go to the exchange and get subsidization. He can't get help from the federal government on his insurance cost. Employees who work at least 30 hours per week or whose service hours equal at least 130 hours a month for more than 120 days in a year are considered full-time employees. That now concludes this section. Now on to your test tips.